Okay, recording.
Okay, so before our break, we were looking at all the physical symptoms that can cause some menstrual dysfunction. Now we're going to look at behavior. There's two components here. So some females have emotional and behavioral changes associated with their menstrual cycle. Again, even though the common myth is you're supposed to be crazy for a few days every month, right? That is not legitimate. So we're going to look at PMS and PMDD. So we're going to start with PMS. That is a wide range of reoccurring symptoms. It's severe enough to impact some aspects of life. Okay. Again, myth that it's supposed to happen. I love this little cartoon. I'm fine, I hate you, I love you, I want ice cream, come here, get away, oranges, right? Like, yeah, that's just life some days. But when it is severe and it starts to impact your daily functioning, that's a problem. So again, this is another one of those real vagues. We don't really know what happens. Exact cause of PMS is not really understood or known. It is behavioral. So I don't want you to think about physical symptoms right now. I want you to think about that emotional one. That's the difference in those two sets we've been looking at. So mood swings, this whole eating thing. But the exact cause is not really known. And the treatments usually come down to lifestyle changes, so salty foods, alcohol, smoking, some of the things we talked about earlier. NSAIDs, great choice, especially because there is a hormonal element that drives some of this. SSRIs, do you remember that from Farm? What's that stand for? Reuptake inhibitor. Remember, serotonin is that neurotransmitter that's your happy thing, right? So if it's not all being removed at once, you've got this whole even time frame, then those mood swings have been shown to be less severe. There are some newer birth control pills on the market that have this built into them. That way it's right there and ready, and you don't have two separate medications to take. Balanced diet is super important, exercise, and the vitamins. So they, right? But SSRIs are different, it's different because this is the emotional behavior side. Now this one, you know, has anybody seen that TV show, Snapped? Okay, if you have a clinical diagnosis of PMDD, I think it must be okay that you shoot up people here. Just saying. You will learn more about this with behavioral changes in psych. Your psych book has a lot of information about this, so if you're just really eager to look at it and learn more about it, it's in mood disorders in your psych book. But this is a true psychiatric diagnosis, okay? And it has to do, once again, with the menstrual cycle. So I think all those women on Snapped, or you know, some of those crazy shows probably have this clinical diagnosis. But this is a more severe PMS, and this is mostly mood. The main problem here, again, is those mood symptoms. And it's not I'm a little cranky. It is I'm going to kill you if you look at me kind of cranky. Okay? That ain't good. So PMDD interferes with work, school, social activity, relationships. Like the horns come out, don't give them a gun kind of thing. The problem is we have to worry because usually these people have a comorbidity, not a comorbidity, it's a health problem. They have a psych issue. So there's some underlying psychiatric issues. And then here comes this hormone swing that feeds this behavioral change. So we really want to make sure that these people are not psychotic, homicidal, suicidal. That's really important if they have a diagnosis of PMDD. And making sure they're taking their medications. So when you talk about bipolar, talk about a bipolar female, you will talk about this a little bit more in the fall, okay? Because it is an actual psychiatric diagnosis. Again, the cause isn't really known. Those risk factors, like we said, the psychiatric history, that underlying history there. Therapeutic management, it's usually multidimensional. So there's some counseling, there's some lifestyle changes, and there's some medications. Everybody loves guns too, right? These people are just, this family okay to be crazy once a month. Again, the goal there with all this management is control of their symptoms. and the behavioral swings that you're seeing that are so severe. All right, so these are the signs and symptoms and the criteria that's used to diagnose it. There's no lab work here. There's no diagnostic, no ultrasound that's going to tell us if you have PMS versus PMDD. It is all about symptom tracking. Let's show you. So, yet again, this is why we want that female to track those symptoms 2 to 3 cycles worth so we can figure out what's going on. Their cravings, their symptom changes. There's an affective component and a somatic. So affective, what does that mean? That's part of your teaching projects, right? What is affective? It's that touchy-feely, right? That emotional piece. And then somatic is the physical, the body systems itself. Okay, so there's 2 sides to this. So the affective side is that anxiety, tension, persistent anger, or just irritability. There can be some depression, feelings of hopelessness. This is why the suicidal, homicidal screenings are super important. They have a difficulty concentrating. Sleep disturbances can occur. Changes in their appetite and their sexual desire. Somatic is the body. They can have all the other symptoms that we have or that people would report normally, but these are just those stronger emotional changes. Okay. The diagnostic criteria, let's see, I put that in here because I got it out of your cycle. Might have got that. Just because I wanted you to know that really to be diagnosed with this, it's more about tracking symptoms. So for PMS, for you to have a clinical diagnosis, not just a suspicion, but an actual diagnosis of PMS, the woman should have charted her cycles at least 2 months in a row and had at least one of those affective and somatic symptoms 5 days before the start of her period. Okay, don't write all that down. I just want you to understand that that's how it's diagnosed, is the tracking of those symptoms. Versus PMDD, so if you want an excuse to be able to carry a gun and shoot people, just report that you're having all these crazy symptoms right before your cycle, and you'll get the psychotic diagnosis of PMDD. Because you have to have at least 5 of those symptoms, of those mood disorder symptoms, before your cycle starts to get that clinical diagnosis. And again, it's the previous 2 to 3 cycles that we look at. So it is based off of female report of those swings because there's no diagnostic testing. So, you want to wait and get on SNAP? There you go. PMDD, right?
I was moving, and if I was pregnant, all the stuff I would at the same time, and I had Verizon, and my phone calls kept dropping. I told her, I was like, I'm going to be in Verizon, and you're going to see me on the news. Maybe like, nursing student loses the Verizon. Just got to shoot me.
Hormones, right? So, and I'm sure we've all these girls, Jeff probably doesn't understand this, he's the only boy in here, well, Dave too. So, but yeah, there's those days where you're just like, I swear, one more thing happens, right? You just feel it building, you're trying to look at honey, just come not today, Jesus, right? You know, just get back in there. Sometimes we just can't help it. You know what's funny? Hangry is a real thing. You know that word, hangry? And they tag this to being hangry. So when a female's hungry, and there's these surges, these changing hormones, and she's not nourishing her body appropriately, balanced nutrition, and then there's stressful events that occur, here comes the devil, right? So believe it or not, it goes right back to being hangry. Who knew that was a real diagnosis? I mean, this wouldn't get it, right? So there you go. If you want to get on SNAP PMDD, go just start writing it down. Questions about that? You will hear more about that when you use that. Okay. So the nursing considerations for either of these, when we assess, you want to be asking those questions. You're going to be using this pretty little acronym, ACDOHO. So you want to know about their symptoms. Do they feel anxious? Is there certain triggers that bring that out? What are their cravings just before their cycle starts? Are they feeling depressed? Homicidal, suicidal screenings. And are they staying hydrated? Super important that they are getting enough fluid intake, not a lot of caffeine and alcohol. And are they having any other symptoms? Anything else, some of those problems that could be physical issues, the length of their cycle could be causing it. So it could be a combined problem, the physical entities that we've talked about, and then we've got this behavioral piece. And again, the management is quite vague. It's going to be education, lifestyle changes, balance out that diet, get some exercise, and try to reduce stress. But PMDD, the big difference there is more physical, more of the emotional symptoms, and that one interferes with functioning. Like they want to run their car into people standing on the side of the road. It's funny, it hurts me. You've been there. There's just one of those days you've been there. I'm just gonna take you to Snickers bar, right? So that's my other favorite commercials. The guy who's, what is that mean looking guy who's got the tattoos and then he eats the Snickers bar and he becomes that cute little girl? Yeah, what's the show? Well, you know what I'm talking about, right? Hangry. Hangry is a real thing. All right, moving on. So we're talking across the lifespan about menstrual dysfunction. So now we're going to look at later changes that can occur as a female gets older and moves into more advanced stages of the development, the middle age to older female time frame. So menopause. Before menopause, which means stopping of that menstrual cycle, there's a time frame where a female goes through perimenopause. So it's usually 2 to 8 years from the time you have the first symptoms of menopause until you have a whole stop of the cycle on a regular basis. And there's just a swing of hormones again. They're coming and going, and it causes all these changes. So the onset or the time frame of this is 39 to 50 years old. But again, this can happen to younger females too. Medications, cancer treatments can throw women into menopause sooner in life. So it's not an absolute, it's a window of time that we consider. Bless you, thank you. The symptoms are usually hot flashes, vaginal dryness, and they're starting to have this cycle, some of that abnormal uterine bleeding that we talked about. Either their flow is getting longer or heavier, maybe shorter. Maybe there's time frame lapses that it's occurring in, so there's some changes with the cycle going on. Perimenopause stops when there has been no menstrual cycle for 1 full year, and that's when you're considered to be in menopause. And usually this is a time frame for that female time of change because she's starting to come into later phases of life. Once she reaches menopause, she's not going to be able to have children anymore. But just because a woman is in perimenopausal time frame, can still have babies. I have a sister who's 7 years younger than me, and it was because my mom thought she couldn't get pregnant no more. So it happens. I tell 40-year-old females several times a week, oh, you're not feeling bad because you got the stomach virus. There's a baby in there. So next week when we talk about contraceptives, we're going to talk about the need to continue to behave if you don't want to be having babies even when you're going through the time frame. Just because you're not having a regular cycle doesn't mean there's not some ovulation occurring. Or you can still be having a regular cycle and not ovulating. So both sides there. So a lot of our role as a nurse in this time frame is more supportive. Making sure they're getting those referrals and keeping them educated. Because there's a lot of changes going on during this menopause transition that's occurring. Okay, and again, this is all real vague because it's just real vague. There's no why to a lot of this. Here's menopause. This is that permanent stopping of the regular menstrual cycle. There's a decline in ovarian functioning, male atrophy. They're no longer needed, so they kind of go away, and then there's a whole host of changes, physical changes that occur with the women in that state of menopause. Remember, you can't be determined to be menopausal until you've had no cycle at all for 1 full year. But that being said, if you have a woman who is in menopause, or in that menopause time frame, and she starts to have some vaginal bleeding, She's gone a year without a cycle, and now she starts to have vaginal bleeding. Is that okay? That is a really, really bad sign. We're usually thinking it's usually a precursor to cancer or an indication of cancer. So any report of vaginal bleeding from a woman who's in a menopausal time frame is a big deal, more so than a younger female. Okay. Medical treatments for menopause. A lot of that is going to be treat your symptoms. The gold standard used to be hormone replacement therapy, but not so much anymore because that feeds other forms of cancer. It's been proven to feed breast cancer. It's been proven to feed cervical cancer and endometrial cancer. So we don't use hormone replacement therapy anymore. It comes down to risk over benefit. When a woman first moves through that transition time frame and there's such a swing of hormones, some providers do choose short-term therapy, hormone replacement therapy, because the symptoms are so severe. It will help with the hot flashes and the mood swings, but it is short-term. Used to, when you hit menopause, you got put on Primer and you stayed on it the rest of your life. But then those people were dying from other problems related to that. So it's risk over benefit, and it's going to be looked at individually. Okay? It's no longer the gold standard for treatment. But complementary therapies are very common. Again, this is a place you're going to see in your book. It talks about calcium and vitamin D. There has been some scientific links that prove that decreases hot flashes. But you can't say why. That's what my brain likes, is that solid why. Dietary. You want to make sure they're getting a good balanced meal. Who knew that nutrition was going to be so important throughout all of this, right? So I give you a couple of practice questions. Even in the developmental stuff about picking out the right nutrition, because the NCLEX likes to throw you nutrition questions because it's that gray area that we're never sure about. So you're going to see a lot of nutritional things there. This is a time too that some females may turn to some herbs, over-the-counter herbal remedies. I think your book talks about black cohosh and different types of teas. Remember, we have to make sure that it's safe for them to take that and not taking other medications. So don't forget to ask about those things with your intake. Make sure you know what you're taking at home, your regular medications, and are you taking anything over the counter, or any vitamins or supplements? Because a lot of times when they're labeled as vitamins, they don't think they're important. But those herbal things aren't regulated by the FDA, and it can certainly cause a problem with other medications. So make sure you're asking about those. We're going to look at the actual impacts on the female body because there are a lot of changes that go on during this time frame. There's the psychosocial elements. Remember this feeling that maybe their time to bear children is over, and for some women that's difficult. They view that as kind of the end of life, and I'm no longer fertile, and I'm losing my role as being a female. Whereas other people embrace that. Ooh, I'm not cycling more, I can get pregnant, let's go have a good time. There's a little retirement community down here where I work called Sin City. At least that's what the people who live in it call it. Because love is free there, apparently, because there's no worries. So next week when we talk about STDs, we're going to talk about one of the higher populations that end up with these problems, and it's because I don't have to worry about getting pregnant, so I don't have to worry about protection. Not so much the case. So making sure that we're helping them consider all options, not just the fact that they can't baby. Okay. Physical-wise, there's a large change in the reproductive system. The hormones that normally would be occurring every month to make those changes are no longer being released. There's a decrease in estrogen. There's an increase in androgens. Have you ever seen those little 90-year-old women and their little husbands, and they almost look like they could be brothers? Yeah, brothers, right? Because the female's got the facial hair. She's no longer got those nice soft lines. Her hair's changing. Her boobs have atrophied and dropped, so you're not even sure if there is some there, right? And it's because the male hormones now are taking over and our female hormones are being suppressed. All those changes occur in that menopausal time frame. Hot flashes are frequent to begin with, and night sweats, they're always burning up. And again, that's the hormone surges and the changes. There's a big risk cardiovascular-wise here. So you will talk about that a little bit more when you're a senior. but it is again hormone-based. We need to make sure these females are getting a good balanced diet, because females die at this point a lot of times from cardiovascular problems. They're higher risk for heart disease. We want to make sure that they're getting regular screenings. We want to make sure we're checking their lipid levels, their cholesterol panels. They're going to have an increase in LDL, and has to do again with hormones. We want to make sure that HDL is your hero. That should be your higher one, right? And your LDL, your loser, should be lower. Females have a problem, and they have a swing in this time frame. So we have to make sure they're getting a balanced diet, and we're paying attention to that, because it does lead to increased risk in heart attacks. And osteoporosis, also a huge concern for a menopausal female. So the osteoporosis, that is a senior concept, but it does fall in this range here that we need to talk about. So we're just going to briefly pick a few high points about osteoporosis. Okay, what is osteoporosis? Bone loss. Okay, and it is because, again, the decrease in estrogen. So females go through a phase where they have bone loss. So they actually can get shorter. You guys remember saying, I think I shrunk an inch or two. They probably have because of osteoporosis. Who is like the classic person for osteoporosis? Like, if we're stereotyping somebody and labeling, oh, she don't have it when she gets older. Who's that classic person? So, a thin-framed female, Caucasian. All of us in here, thin-framed, small-boned females are highest risk for osteoporosis. Okay? So we want to make sure calcium intake. Calcium intake is really important and should be started early on. Don't wait till they're already in menopause to tell them to start taking calcium every day. Around the age of 25 really is the best time for females to start taking calcium supplements. And even though you can get 1,000 milligrams over the counter, you really shouldn't take all that all the time because your body can't use it. So you should take 500 in the morning, 500 in the evening, and they need to know that and understand that. I drink a gallon of milk in about 2 days. I love milk. I just hope that when I get old, I'll stop just drinking more. Okay? But it makes sense if you think about it. Who breaks their hip all the time? The old ladies. You don't really see old men with broken hips, right? No, because it's not really a male problem, it's a female problem, because of the decrease in estrogen, and they have this bone loss, and the increase in others estrogens. So you will talk about it a little bit more. We're going to look at, try to see what I got on here. We're going to look at the scanning, how we scan for that, because that's part of your routine screening. But it is a highly preventable complication of menopause, and it is due to the decrease in estrogen. Small, thin-framed females, calcium and vitamin D, that's your biggest thing. And weight-bearing exercises. Females, even in menopause, should get some regular exercise. Walking, those little 5-pound weights. I love to go to an exercise class and it'd be a little older ladies. First of all, if they can do that, I know I can do that, right? And then second of all, I'm just thinking that's good for them. And then yoga and stretching and things like that, there's a lot of benefit to that. So over here on the side are some of the physical symptoms, broken down by the body systems, because that's how your book presents it. So there's the whole hot flashes, sleep disorder, mood changes, memory problems. Heart, here we go again, we want to make sure that they have that higher level of HDL, but typically it's lower, and it's because of the changes in the hormones that level is lowered out, and that puts them at higher risk of heart disease. The bone loss, we talked about why the breasts start to sag. There's ducts, the milk ducts that normally are there to produce when you're in childbearing age, to produce milk and feed your child. You're no longer doing that anymore. So there's glands atrophy, they shrink, and then that tissue becomes fat tissue, and it's heavier, and they sag, they drop down. All the things we got to look forward to, right? Vaginal dryness is an issue because, again, there's no estrogen there to release that natural lubrication. So they may come in and talk to you about the need for lubrication and sex. Okay, you need that to be comfortable having these awkward conversations with other people. And next week we're going to talk about that a little bit more too. But some KY jelly goes a long way because they can still be sexually active, whether you want to think about that or not. They Just saying. Don't just assume because they're 60, they're not doing things like that. Or 70 or 80 or 90. GI, there's less calcium absorbed, so they're more at increased for fractures. So making sure that they are breaking apart of that calcium supplement if they're taking it is super important so their body can get out of it what they need. Plus, they're more stationary. So we know that that reduces the calcium in the bone because it's being released when you're stationary, right? All that stuff we can do something. And their skin becomes dry, thin, there's a loss of collagen, and all that is again driven by estrogen. Okay. So you'd think hormone replacement would be a great thing, but remember it does cause those problems. It's risk of benefit. So nursing considerations, we want to make sure that they are getting screening for osteoporosis, cardiovascular disease, and they're continuing to be screened for cancers. We think about breast cancer in this grouping of women. We also think about cervical cancers. Just because they're not wanting to have children, they should still be going and having routine physical exams, seeing the gynecologist. So we're going to look at those screenings at the very end and the time frames and the recommendations on those, okay? Lifestyle strategies, that includes good balanced diet, that regular exercise, managing any of those comorbidities they already have, making sure they're taking regular medications, all that basic stuff, nothing glamorous there. And the reduction of risk. Grandma probably doesn't need to be on the skateboard, right? If she does, wear a helmet at least. And then the education is here. It's the basics. It's the same things that we've been talking about. What's new here, what's been added is just the sexual activity. You want to talk to them about disease prevention and then making sure that they have proper lubrication. That is something they want to be engaged in. Okay? We'll have that conversation. That would just make your prep tool change a little bit. You know, there's that question on there, normal development. Think about where the one question's about sex or sexual activity or sexual, I forget exactly how it's phrased, but you know what I'm talking about, right? 111 now. Can we ask them about sex? And now you kind of see how that sort of changes over time and why that becomes really important to consider because holistically we care for that person. All right, during menopause, a woman may end up undergoing a hysterectomy. Menopause is the only reason that wouldn't be a cause for a hysterectomy. They may have endometriosis. They may have cancers and other reasons that they may need a hysterectomy. This is what your BSIM is all about this week, right? Who's done BSIM? All about her having a hysterectomy and then some of the complications that go along with that. So this is in your med-surg book. I don't believe it's even really in your REACHY book. The hysterectomy is the surgical removal of the uterus. It can be done to treat cancer. It can be done for dysfunctional urinary bleeding. Endometriosis, remember this will be definitive treatment for endometriosis because once that's out, there's no babies being born. Non-malignant growths, persistent pain. It can also be done for pelvic relaxation or prolapse and any previous injury to the uterus. It is really freaky to do an assessment and see the uterus prolapsed out of a 90-year-old. Okay. It's there. So making sure that we are looking, a good nurse will ask, a great nurse will look, and this is one of those opportunities. Okay, nothing should be hanging out down there. This picture is of a laparoscopic removal of a uterus, and it really shouldn't be that large. This uterus probably has a tumor or something inside of it. There's some type of growth in that one. It shouldn't be that very big. There can be a total hysterectomy, a radical hysterectomy, and then it can be done in different ways. So total is removal of all those female organs. That person may need some short-term hormone replacement therapy because that uterus and cervix are both coming out. But again, it's risk over benefit. A radical, the whole uterus, the sides of the uterus, the neck, part of the vagina, all that's taken out. And usually that's done because of cancer. So whenever the female says she's had a hysterectomy, it's best to try to figure out how much is left behind. That would kind of into what some concerns that we may have. It can be done laparoscopically. Again, that's through the abdomen, especially if we're thinking about endometriosis. That'd be how it would be diagnosed, and then it can be removed that way, and that's what this picture is of. It can be vaginal, so they can go up inside and just pull it out, or they may have to make an abdominal incision. So this is surgery. So the nursing care of this is that pre-op and post-op type care. Your med-surg book lays out an entire plan of care for a female who's had hysterectomy. Right now, today, we're going to think more about that post-care. You will talk about this a little bit more as a senior too, but your VSIM is dedicated to hysterectomy, so I'm going to give you some things to think about, okay? So these are the nursing considerations. Clearly, if you're having all your female organs pulled out, there's a little bit of anxiety, right? So we want to allow them the opportunity to express their feelings. Physically, they need to know what to expect. The word anticipatory guidance, have you been seeing that as you've been reading in this book? Because that is all through this book. So this anticipatory guidance, in essence, means the nurse is able to guide this person through this phase, understanding what's to come, and being able to explain those changes to the female, and helping guide her through this phase. It applies to children, women with brand new babies, women who are pregnant and moving through this phase, and even here when we're talking about menopause and the changes that can occur. So explaining and helping guide her through that. And of course, providing that emotional support. Because there is that loss, that feeling of loss for some females. So again, that expression of feeling. This is all in your med-surg book, okay? So don't crank your hand trying to keep up, just let it make sense. Pretty much the interventions are very similar, but maybe for different reasons. Pain, we want to make sure that we are addressing her pain. We want to assess it. We want to treat it, both pharmacological and non-pharmacological treatments. We want to teach this person about their pain control measures, about the ways they can position themselves for comfort. And then we want to make sure that we're reassessing for that pain, that discomfort. And then knowledge deficit, I told you a long time ago, way back when, knowledge deficit applies to every single person, right? So always think about knowledge deficit when you're creating your plans of care. It doesn't matter if we're talking about the new mama, the postpartum female, this hysterectomy person. Knowledge is huge. This female is going to need to know how to take care of her incision, especially if she's got that midline abdominal incision, or with the laparoscopic procedure, there's the small puncture wounds on the abdomen. They're typically glued shut. She needs to know how to take care of that, what to expect. Bowel and bladder function is important. Sometimes if there's a issue with the prolapsed uterus, this female is not having regular bowel movements, and there's a problem urinating. So once that's pulled out of the way, you need to make sure that you're able to help her return back to normal functioning. When to resume activities. This female is in essence almost like a postpartum mom, right? If something's come out, now we've got this window of time where there's no heavy lifting, depending on how this procedure was performed, when she can return back to that. Slow return, because as she ages, her ability to heal also changes and slows down a little bit. And then things to avoid, probably not going to be in the bubble bath right now. Probably not want to be returning to sexual activity right away either. Symptoms to report, and then the follow-up. And of course, absence of complications. If you think about a postpartum woman with a hysterectomy, or a woman who's had a hysterectomy being like a postpartum mom, we want to make sure that we're paying attention for the risk of hemorrhage, because really there shouldn't be a large blood loss for this procedure. She's going to be more at risk for a DVT, so those STDs that we played with in Sim Lab, we talked about making sure that she's wearing those when she's in your facility, and then up and ambulating after that. And the risk for bladder dysfunction too is a problem. So this is laid out very nicely in your med-surg book. It's about 2.5 pages of the entire care for a woman with who's had a hysterectomy, and then again it is the basis for your VCM this week. Okay, it's all the things we think about. It's our summer school. Okay, so we're going to move into a different area now, and I'm just going to tell you this next topic tends to bring about some emotion. we're going to talk about factual information, and we're going to let it be what it is, and we're going to move forward, okay? So I have had classes that want to get into debate about these next topics, and I'm just going to tell you, I welcome discussion, but we have to remember as a nurse, our role is to support and advocate for care, not make decisions, okay? So let's take a peek at family planning. We talked about some of this already with Ms. Washburn. The two things we're going to talk about here are infertility and abortion, okay? So first of all, I want you to know that you should not walk out of this class this semester feeling like you're an infertility specialist. That is not realistic, okay? Infertility is a very common problem, and you're going to see this no matter what area you choose to work in. So we're going to think about this holistically as a nurse, and I'm just going to tell you, I apologize, y'all, I left this on because just in case, and now it's all crazy. There are some really nice to know words. Your book gives you a great bunch of nice to know procedures. If this is an area that interests you or has a personal touch to you, I encourage you to look at that, okay? Really look at it and understand it, and if there's questions you have, I'll be happy to try to answer them. But this is a very tender subject for a lot of people. So we're going to define the terms and have a basic understanding. That should be what we come out of this course with, okay? So infertility is defined as the inability to conceive after 1 full year of trying. Unprotected sex, okay? Trying and trying and trying to have a baby, it's just not happening. There are 2 types of infertility. There's primary infertility. That person has never conceived, ever. And there's secondary infertility, and that person has been pregnant in the past, but they're not able to conceive again. That doesn't mean they have babies at home. Okay, that might be your G2, P0, because it just hadn't happened. But then this person's continuing to try and try and try, and now for this whole year of time, they've not been able to get pregnant. So primary and secondary. There's a huge impact with infertility. Some cultures expect you to have as many babies as you can, as often as you can have them, right? Some cultures don't believe in introducing medications to augment a role that we should be able to take on. Males blame females, females blame males. It becomes a pretty ugly little process along the way, whether it's meant to be or not. So it does have a huge impact on the person, the couple, their relationship. So being mindful to that is really important. I learned a long time ago it's a really bad plan to ask young married couples when you don't have babies, right? Because you don't ever know what's going on. So while you're excited for them and you want to encourage that, for some people that is just a knock upside the head. They are working as hard as they can and they're not able to live up to that ideal role of what a family should be. So that is a hard thing to think about. This is very common. This book gives you some really crazy statistics that every time I read it, I'm always like, it's kind of sad. But I love to see the Facebook pictures like this one, where the person is announcing that they are pregnant, and then you see that backside story of what they've been going through and all the different treatments they've gone through. So it's a lot to consider there. Remember, our role is to be supportive emotionally, physically, and making sure they're getting the referrals they need and factual information, because this is a very difficult topic for a lot of people. So primary, secondary, okay, terms. This whole section is all about terms. So when there is a problem getting pregnant, there are multiple factors. Your book says it's about 40% male problem, and a 40% female problem, and a 20% combo. So once there's been this whole year of time frame where they've been trying and been unable to conceive, then some testing needs to occur. It's usually not done right off the bat, though. They will try for a while. We want to look at the semen sample. It requires the male to give us a semen, because now we want to see how many swimmers are there. Are they viable? Is there one in there? What's the likelihood of that one getting all the way up into there and making an impact? Not a lot, right? The use of medications for men. Some men use things that cause a problem with their semen production, their sperm viability. So we got to really get in there and assess and see what's going on the male side. Boys may need to go and have some physical, internal and external exams. If there is an enlarged prostate, that can be causing a problem with the flow outward, and they may just not be making it outside. So a lot of testing has to happen. And the same thing for females. We have to make sure hormone-wise, all those other things we've already talked about, there's other diagnostic tests we look at and want to know, are their ovaries even functioning? Your book says you have about 400, I believe, viable eggs that are released over your lifetime. Some people don't have those. So we need to know, are they functioning and are they being released? And is there any issue in the pelvic organ that can be preventing this? So there are some labs and diagnostic tests, again, in your med-surg book and your Reachy book, blow this out, like way out. There are tons of things. That is really great to read so that you're educated if this is an area you're going to work in. But that is in no way realistic for this program, this course, this semester, or this test. Okay? I don't want you spending your wheels on things. As a nurse, we do need to know, are they having these issues and kind of what they're going through. Because some of these labs and diagnostic tests, some of these medications can cause some side effects that can lead back into those earlier problems we talked about. The changes in the menstrual cycle, the hormone swings from PMS. So you do want to know kind of what they're doing at home and how it's being dealt with, okay? So medical management of infertility. We need to correct modifiable risk factors. Smoking, clearly that leads to all bad things, right? Weight loss. If a female is overweight, they have a harder time getting pregnant. So weight loss and nutritional counseling is important. Anything that we can do to change it, we want to make sure that those are being, that she's able to do that. Medications. Sometimes it's just a problem with ovulation. Remember, you can have a menstrual cycle and not be ovulating. So there are medications that can help induce ovulation. There are surgical procedures. They can be artificially inseminated, all those advanced reproductive technologies that your book talks about. That's great stuff. But what the nurse needs to know, again, is what is this person doing if they're trying to get pregnant and they're in this window of infertility? Because those meds can, again, impact the cycle. It can cause some unwarranted side effects. They can have bloating. They can have ascites. The ascites can lead to a pleural effusion. All that's from medications they're taking at home trying to get pregnant. Plus it causes mood swings, food cravings, all the other things that we talked about earlier. Okay. You also want to know if they're trying to get pregnant before other basic medical things are, medical treatments are ordered, because some treatments are contraindicated to a woman who's trying to get pregnant. So you want to make sure that you ask those questions, you think about that. Are you trying to get pregnant? Are you thinking about getting pregnant? Because that may even matter when they're being prescribed an antibiotic. So you want to be aware, because the doctor's not always thinking like that. It's a really good time to say, hey, they're working on getting pregnant at home. I know you're going to order blood pressure medicine. And they're like, oh, thanks for telling me that. I didn't think about that. And then they'll look at it a little bit differently. The nurse is the holistic care. So you want to make sure you keep it in mind. All right, so nursing considerations for infertility. You know, this couple's being beat up a lot. The woman's usually feeling like she's a failure, regardless of whose fault it is. It's not important about finding blame. It's important about empowering them. There are a lot of advancements in infertility, reproductive technology. You're not going to find those down the street at the doctor's office. This person needs those referrals out. Usually there's some genetic counseling that occurs. Empower them to seek out what they need. Okay? It's not okay to say, it'll be okay, you'll get pregnant next time. Because to somebody who struggles with this, that is just a huge insult. Okay? Advocate, make sure they're getting what they need. Respect for that couple. Some people end up in therapy, some people end up divorced. They're not able to conceive. It is a huge toll. So respect that couple, and again, you want to make sure they get referrals that they need. Education, anticipatory guidance, there's that word again. Because throughout this process, there's going to be a lot of ups and downs. So as a nurse, having that perspective of what may occur, especially if this is an environment that you work in, and being able to guide them through that about the phases, what might be tried first versus what might be tried later on. We're not going to go straight to artificial insemination. They may try things like medications, cloned first to release multiple eggs instead of just one egg, and then move on into some of those. These things are costly too. Insurance doesn't cover them. So artificial insemination can be $20,000. So there's just things to consider.
Why do you need it?
Because of PCOS, which places to go ovarian disease, because there's a link with that and blood sugars. So they'll use the metformin to suppress that, control your blood sugar, encourage weight loss. Easier sometimes. Both of my sisters have PCOS, just both of them. My oldest one especially, she now is diabetic and is on insulin all the time, but she was trying to get pregnant. She was on metformin to control it, and then gestational diabetes. And that's very common. That's usually the course for a woman who has PCOS. Okay, but that's important to consider too, because you can't have a CT scan. So by taking metformin to check their renal function, right? So that's the med-surg side of this. Some people resort to all sorts of things too. You've heard about people buying babies on the internet, snatching babies out of hospitals, and all that sort of thing. So make sure that you get these people referrals that they need, because that's the most important thing. They need that support, and they need the physical testing. They need all the things that modern medicine will give them. But they also need that support group, and there are lots around for that reason. All right, clinical interruption of pregnancy is the other name for an abortion. Remember, it is the end of pregnancy before the fetus is viable. And the definition of viable is determined state to state, and it changes all the time. A lot of people have a lot of emotion when we talk about this. Here's what I want to tell you. As a nurse, if this is not something that you think you can support, don't put yourself in that situation, right? The American Nurses Association states that a nurse can refuse to participate in the procedure. In other words, don't go to work at Planned Parenthood, right? You can refuse to help with the procedure, the actual procedure. However, you cannot refuse to take care of your patient. That's negligence, okay? So if you're going to see a person in this situation, no matter where you work, you have to stop and consider your own thoughts, how you feel about it, before you can decide, is this somebody I can help take care of? And if you know, ethically, you cannot take care of this person safely, you should not accept assignment on that patient. Once you receive a report, you have accepted assignment for the care of this person, and your role then becomes just like anybody else. You're going to take care of prisoners. You're going to take care of drug users. You're going to take care of females who have chosen to not continue with their pregnancy. So you really have to think about your own biases, and that really needs to be set aside. Because again, the ANA says you don't have to help do it. So don't go put yourself there. But it is our job to safely take care of these people and make sure they get what they need. Okay, I just want to throw that at you right now, because that usually ends up being the conversation. These aren't always done because she chooses not to have a baby. There are a lot of reasons why a female may choose to not continue with pregnancy. There might be a problem with the fetus and its development. Okay? There might be a problem medically that if the woman continues with the pregnancy, it could cause her and the baby to pass away. can try again later on, but continuing it right now might be detrimental. So again, this is understanding holistically it's her choice, and being supportive of that. It's not okay by anybody's world to try to talk her out of making decisions for herself. Okay? So an elective abortion is the female's choice to end the pregnancy, but not always because they don't want to have kids. Just think about that. It can be done 2 different ways. It can be done medically, so that's with medications, and that's usually within the first 48 days of conception. Just that first trimester, 48, 49 days, that first trimester, basically. So these are the 3 most common medications that you'll see. These are some big words to say. The first one is RU486, right? We hear about on TV all the time. People don't always understand that. What that medication does, it blocks progesterone. So what's your hormone of pregnancy? So what it does is it blocks that. So the endometrial lining doesn't stop its whole process. If progesterone is there, it helps that pregnancy to flourish. So if they take RU486, it just blocks that. It prevents that hormone from sitting there and letting this environment start to grow this baby. That'd be like plan B. Yeah, we'll talk about those next week too, the emergency contraceptives. Those are hormone-based a little bit. This one is truly blocks progesterone. Okay, the other ones are more like birth control. So we're going to look at those next week specifically. Okay, but RU486 is the generic name. I love saying that. This can be prescribed in a doctor's office, filled in a pharmacy, and they go home and take it. And it blocks that progesterone. And then they also need the bottom, which is the generic name on the bottom one is Cytotec. Cytotec is a prostaglandin. What do prostaglandins do to you? It causes those intense contractions. So they would take RU486 to block the progesterone, and then they would take the Cytotec to create the contractions so that it is expelled. The other option there is a drug called methotrexate. Methotrexate is pretty common because it can be used for cancer patients and other problems. What methotrexate is toxic to rapidly dividing cells. Well, what is the fetus? Early on, rapidly dividing cells. So methotrexate is used, again, orally, and then it's followed up with the Cytotec. So the methotrexate stops the division of the cell, and the Cytotec creates those contractions within the uterus because it's prostaglandins, so that it is expelled. So it's a combination, and it's based off the provider. If this is prescribed to the female and you are seeing her, they're going to have all the general questions they have about medications. So having a basic understanding of how they work is important. She should expect some cramping, normal cramping, kind of like the start of the cycle, and pretty much a normal flow. Because remember, this is that first 49 days of conception. She should not expect a large amount of anything, severe cramping, nausea, things like that. Because there are some unwarranted or side effects to this that can be dangerous if they don't pick up on it. So they should no way expect anything really major to occur, just because it's about a menstrual cycle. It can also be done surgically. Surgically is usually more in that second or third trimester, and really it's going to be based off the size of the fetus and the gestational age as to what's done. The 2 options are vacuum aspiration, so that would be through basically through the vagina into the uterus and vacuum suctioned out, or a D&E, where it actually has to be dilated as if you're giving birth and then scraped out. The inside of the uterus is scraped out. And again, this can be done because the fetus died inside the female. So now this is almost like inducing birth. So I want you to really think about this as a nurse and realize our role here is to advocate. Don't associate that word always with a choice of not to have children. Okay? Really have to examine your own biases on some of these things. So that, now we're going to look at the word spontaneous abortion, kind of compare and contrast. Spontaneous abortion is when the body does this normally. So a medical abortion is done with medications or surgical procedures. Spontaneous abortion is the other word for miscarriage. And that again can happen just by itself. The body realizes there's a problem with this pregnancy. And that's usually in that second or third trimester. And then it will just expel it. So it's clinical interruption of pregnancy is the umbrella for these terms. A woman who has a spontaneous abortion, she can have a complete, incomplete, and then she can be what's called habitual. So incomplete, not everything was expelled. Therefore, she may be your med-surg patient who's having a DNE or a DNC completed to remove the remaining parts of the content because not all the content of conception was expelled at that point. The os could be closed or opened. If it closes back and there are products that are contained inside, she's going to get an infection. She could die from it. So she needs to understand that and why it's important that she gets her follow-up. A complete, it opened, all the contents were expelled, it closed back, it's over with kind of thing. Or, and the word habitual means it happens over and over and over again. So I put those terms on your terms to know. Your med-surg book talks about spontaneous abortion, whereas your REACH book talks about the elective abortion in those terms, okay? It comes down to just knowing ourselves and being able to deal with this thing. Understand it. Okay. All right, again, our role, regardless of how you feel about it, we still have to advocate for her. She needs education, she needs to know choices, and those have to be presented without bias. There are options, right? She could choose to go through this pregnancy and give this child up for adoption if it's a financial issue. She's helpless and she doesn't want to bring this child into that situation. You know? So making sure that she is aware of options. Factual, only factuals. Don't send her to your church or pray for her. That's not fair to her, okay? She needs to kind of know what to expect. There will be an exam and lab test. We have to confirm the pregnancy. They want to look at the hormone levels. Again, if this is a problem with the development of this fetus, there's going to be extra testing that goes on. And think about now this couple who's had problems with infertility, who's now been able to conceive, who has to ultimately make a decision about the continuation of a pregnancy. It can be sad. So advocate for them, provide that emotional support. Patient education is huge. If they do choose to go through one of these procedures, knowing what to watch for, complications to expect. Once the actual procedure itself is over, it's kind of like a postpartum person. We really don't want them putting things up in there, so they should be wearing a pad because there is going to be blood flow. Probably don't want them resuming sex, right? Not initially. They need to come on for a follow-up appointment. Typically, that's about a 2-week time frame. They need to return, make sure that they're followed up and seen. That's a great time to be thinking about contraceptives for the future if this is not something that they want to do again. So that would be great education to provide them. They need to know to watch for fevers. Their discharge should not have a foul odor. Remember, it's just like a menstrual cycle. So a fever, a foul odor, crazy abdominal pain, those are all problems. That would be a reason to come back in and be re-seen. But some of those problems bring females to my department on a frequent basis and then figuring out what's going on and asking those questions. If it is a female who's elected to stop a pregnancy because she just doesn't want to have children, some of those females carry an amount of shame and they're not always forthright with that information. So getting that, creating that nice therapeutic environment to let them be able to talk to you and realize you're not there to pass judgment against them is difficult because they're kind of feeling embarrassed or ashamed or unsure of how to take that. So observing complications, education, super important. They should resume a normal menstrual cycle within 4 to 6 weeks, depending on where they were when they elected to stop this, and making sure that they get follow-up appointments as needed. So nothing up in there, just like a postpartum woman, right? All right. How about another little break before we look at this last little section, which is basically screenings and the health promotion section.